Thank you, Mr. Chairman, for that kind introductions. Good morning, ladies and gentlemen. It's my great pleasure to join. I think this is my fourth time in 4 consecutive years. I already enjoyed this HCV meeting. However, as you know that I'm a hepatologist, so I will a little bit move away from HCV to update on HCV diagnosis and treatment. Here is my disclosure. Let's start with about what is new in diagnosis of hepatitis C infections. This currently, as we know for a long time, we start with the screening test by using ELISA. The problem of ELISA is, you see, the earlier generation of ELISA, they detect only one protein of hepatitis C. Therefore, it takes quite a while to be able to be detected. It takes me 8 to 8 weeks after the onset of acute hepatitis C infection. The later generation, particularly third generation of ELISA, you can see they combine a lot of hepatitis C antigen, and this allows earlier and more sensitive to detect anti-HCV. Once HCV, anti-HCV positive, we call screening test. It depends on the list of population. If in the high risk population, you can see that over 90% positive predictive value that the patient had actual hepatitis C infection. But in contrast, those who had low risk, it's just about 50% risk of infection. Therefore, we still need to be confirmed diagnosis hepatitis C with nucleic acid test, that is HCV RNA, which is quite complicated, and in Thailand is still quite more expensive and require expertise to perform this test. Therefore, now in 2017, we developed the new, easier, simpler, and less expensive test for hepatitis C infection, and that we detect the core antigen of hepatitis C virus that called HCV core antigen. So this variety of assay and also the sensitivity, you can see now the more popular one, we use the AdBox architect HCV antigen core antigen. As you can see that the sensitivity is down to 0.06 picogram per mil, and that equivalent to around 500 to 1,000 international unit per mil of hepatitis C RNA viremia. So this, the good of this C core antigen, you can see that is cover all genotype of hepatitis C. You can see genotype 1A, 1B, 2A, 3A, 3B, 4, 5, and 6. That all genotype hepatitis C. You can see that this C core antigen can cover all pan-genotypic of hepatitis C. The problem is, you can see that sensitivity is quite vary depending on the genotype, with the least sensitivity seen in genotype 2. However, if you look at the HCV RNA and in correlation with C core antigen, it shows you perfect, good linear correlation, and that this will be equivalent to about 3 to 10 femtomole per liter of core antigen, and this is equivalent to around 1,000 to 3,000 IU per mil of HCV RNA. The problem is, if the patient have really low viremia, we might miss that group of population. The good news is, you can see most of the hepatitis C patients, they always have HCV RNA over 10,000 IU per mil. Therefore, limit of threshold to around 10 IU per mil is sensitive enough to detect all HCV viremia patients. And this, as you can see, the correlation between HCV RNA and core antigen in the term of over period of acute infection. As you can see on the presentation, HCV RNA core antigen will be earlier detected after onset of acute hepatitis C infection, and this about 2 to 8 weeks prior detection of anti-HCV. Therefore, to use HCV RNA viremia and core antigen, you can earlier detection those who suffer from acute hepatitis C prior detection of anti-HCV antibody. And therefore, we use this kind of core antigen. In the old day, we used HCV RNA. Now we had core antigen with quite good enough, less expensive, simpler, and it automate. And you can see that during the period of acute infection, you can detect either HCV RNA viremia or say core antigen of hepatitis C, and that prior anti-HCV antibody detection. The other hand is you can use to detect who actually still have active infection. Some patients, they may have positive anti-HCV, but actually they spontaneously resolve from hepatitis C infection, or they've been cured by DAA therapy. This, as you know, that anti-HCV will be perceived for the rest of their lifetime. So sometimes you detect anti-HCV positive, it doesn't mean that they have active viral infection. So this also show you in among HCV and HIV co-infected patients, they use the core antigen to detect active hepatitis C infection among HIV positive patients. You see the first one, core antigen positive in almost cases of those who have actually HCV RNA viremia, 95%. Actually, two who were negative by core antigen, you can see that because they had really low viremia, only 200 and about almost under 350 IU per ml, and that patient either will resolve spontaneously or someday they will have active replication and you will be able to detect HCV core antigen anyway. And you can see HCV antigen in diagnosis of acute hepatitis C among HIV positive patients provide you almost 90% sensitivity and 100% specificity and really good correlation up to 0.97. Therefore, in the term of update in diagnosis of chronic hepatitis C infection, we still start with screening with anti-HCV positive because it's simple and it can mass screening in the community, and some countries like France, they even use saliva of the patient. They can detect anti-HCV, so it's still the simplest way and convenient to perform screening tests. However, once the patient have positive anti-HCV, particularly in 2018 when million of the patients being treated and cured from the disease, to get only positive anti-HCV, you might include some patients who not actually require treatment because they've been cured from hepatitis C infection. So this still need to be confirmed, or they will be HCV RNA. However, in 2018, we got core antigen of hepatitis C with the price of testing C core antigen, it might less than half of the HCV RNA, and it's not require expertise for the technician, and it's automate. You can do quite a lot in the quick periods of time and really easy. If HCV-RNA negative, it means that the patient have anti-HCV but not truly active virus C infection. We just repeat again, either core antigen or RNA in next 3 to 6 months. If it's confirmed negative, we consider this patient either fall positive or cured from previous infection spontaneously or by hepatitis C treatment. But if core antigen become positive, can I have lesser pointer? I don't see the pointer on this one. Okay, so if the patient have positive either RNA or core antigen, then we confirm diagnosis of hepatitis C. Therefore, we are said to see the severity of liver disease and also evaluate comorbidity and co-medication. As you know, there are a lot of drug interactions. And once HCV-RNA quantification confirmed, genotype confirmed, then you can consider about treatment of the patient. And with, I'm going to go to my second part in the new or update in hepatitis C treatment with a very highly effective pan-genotypic DNA. We might not require to perform genotype because one regimen can cover all genotype. However, we will talk a bit because I will say that don't allow the perfectness to destroy the goodness, because sometimes you want to be too simple. I will give one example. Like the patient with genotype 1A and 1B, if you don't do genotype as well, and they had DA experience, for genotype 1A, you require software work, which is more expensive and not available in many countries. But if they genotype 1B, you can rescue therapy just by software, less expensive and available worldwide. So that's some example. Probably genotype 3, we just public now it in place. We saw that in Thailand, probably in China, have genotype 3A and 3B. 3B is difficult to treat. Now, even with the perfect of good regimen, the SVR is just around 70%. Comparing with 3A, it's up to almost 100%. So therefore, among the perfectness is still something that we might, to be a good practice, you might to take consider in some particular issue, particularly where you live in the area. You have high prevalence of genotype 1b, like in Thailand, 70% of genotype 1 is genotype 1b, and about 20% genotype 3b. So in some population, in the country where 90% genotype 1a, you might not consider to perform genotyping. So, however, among those who just acquire infection, as I mentioned earlier, that it takes about 4 to 8 weeks to develop detectable anti-HCV antibody. And also in some immunocompromised patients, particularly patients with chronic renal failure who are on dialysis, you can see that false negative anti-HCV, it can up to 10 to 15%. Among that group of patients, you might confirm diagnosis by testing HCV-NA or HCV core antigen in order to not miss the patient who have false negative anti-HCV. So this concordance between core antigen and also HCV RNA, you can see even at the baseline before treatment, it gives you almost 100% concordance. And week 4, that means on-board treatment monitoring HCV-NA, how they respond to your treatment. You can see that up to 12 weeks, that usually is the most of the HCV treatment regimen now, it finished at 12 weeks. You can see at the end of therapy, you also had concordance up to 100%. That means you can use this core antigen to confirm that your patient actually responds to your treatment, and to confirm certain response. You know that SVR24, that means undetectable HCV-NA, 24 weeks after the end of therapy, it almost same as of cure. It almost 97% cure. So you can confirm that the patient cured from hepatitis C by looking at HCV core antigen 24 weeks post-DAA therapy. And you can see concordance is also up to 100%. So therefore, this core antigen can use in many things. One is screening. Screening, we still prefer antibody testing because it's cheaper and can do mass screening, and some countries can use it in saliva. You don't need to take a saline with you. And one anti-HCV positive, it will be confirmation of hepatitis C infection. You can do the all-day HCV-NA testing, that more expensive and time-consuming and require expertise of the performer. Now you can use core antigen, that half price of the HCV-NA, automate and not requires expertise, and that can confirm diagnosis. And again, among those who have acute hepatitis C or immunocompromised patients who not have detectable anti-HCV DNA, you can use core antigen to diagnosis of acute hepatitis C. Once the patient on board for hepatitis C treatment, now you can use core antigen as well instead of RNA to monitor how they respond. Usually we not recommend for testing the response anymore because it almost 100% cure. Why you have to test how they respond during the treatment? We test adherence of the patient, the compliance. If week 4, week 8 still high viremia, you can see that almost 100% the patient has poor compliance. So we use that thing in order to check the compliance of the patient, particularly those who still concerned about adherence to therapy. So we not confirm effectiveness, we confirm the patient instead of the regimen. Therefore, when at the end of treatment, again, in Thailand, we not recommend to do HCV antigen at the treatment because you know it almost 100% respond. Why you have to check that? We save money to get drug to more patients. So we check at least 12 weeks post-treatment or 24 weeks post-treatment. If core antigen negative or RNA undetectable, we can consider that patient cured from the disease. So up to the treatment regimen, it's very easy to talk about update hepatitis C treatment in 2018. I just show you the one color appear in pink color. You see this a new drug that also available in Thailand and many countries. We call sulfonylurea, Hepatology. In country where Gilead allowed the generic to be marketed in the country, you can see the treatment regimen, it cost you only about $500 to $600 for 12 weeks. And you see, this very simple. If the patient hepatitis C treatment naive, that means they never been treated with pegylated interferon ribavirin or DAA. Either they have cirrhosis or no cirrhosis. what genotype they are. You can see 12 weeks soft well give you at least 97% cure rate. So now I just don't care another one. If you had the one in Thailand as well, soft well will be licensed in Thailand by the second quarter of this year, and this will be universal coverage. All Thai patients can be treated with soft well for 12 weeks for genotype, and we recommend not do genotyping, only some specific patient and some medical center with a good reason why you still need to do viral load and genotyping. Why we do this? Even I said don't allow the perfectness, but I begin to do some perfectness, have some weakness, because we want to keep money to treat all Thai patients. So if you spare testing genotype and viral load, you might able to treat more patients, because we still in an economic constrained country. So in those who have treatment experience, not DAA but pegylated ribavirin treatment experience, you can see it's still 12 weeks soft well without ribavirin, without interferon, except one genotype, genotype 3. Genotype 3, particularly genotype 3 with Selosit treatment experience, we just published recently with 12-week treatment regimen without ribavirin in genotype 3 Selotic, because in Thailand, half our patients genotype 3. So therefore, we have to bear in mind. So we use a soft well without ribavirin, 12 weeks among genotype 3 Selosit, PEG ribavirin treatment experience. We achieve SVR just only allow 80%. Now, for hepatologists with DA therapy, anything below 95%, we saw suboptimal response. We want SVR above 95%. So therefore, we had to add ribavirin for 12 weeks in this particular group of patients, genotype 3, Selosit, and treatment experience. You can see adding ribavirin for 12 weeks, you achieve about 98% SVR. That we quite satisfied. So the story not end at this one, because new drug coming. And it might coming in some country already, in European and USA, they have gicapivir and preventesvir. It fit those combination in one tablet, but because it contains low dose, you need 3 tablets a day, need 3 tablets one time a day. You can see it perfectly effective pan-genotypic from genotype 1 to genotype 6, and with treatment regimen, the good news, you don't need ribavirin. Ribavirin also contains some side effects, coughing, skin rash, and hemolysis. So this one, without ribavirin, it had no problem regarding the side effect. And no interferon, that's a very good news for the patient, because anyone who been treated without interferon and they never complain about side effect, they get placebo, not to PEG interferon. So you can see with this interferon-free and ribavirin-free GP treatment for 12 weeks, pan-genotypic, even in serotic or non-serotic, you achieve 99 to 100% cure. Okay? So, and another one, this another good study is HIV, HCV co-infected patient. It also very highly effective. And the good thing from this study, this expedition 2, they explore can we shorten the treatment duration from 12 weeks to 8 weeks. I think 12 weeks is good enough. Now it's 8 weeks without ribavirin, without interferon. Even in HIV co-infection, you can GP treatment for 8 weeks. In non-serotic, it achieves 100% SVR. But for serotic, it might compromise SVR down to around 83%. Therefore, we recommend to use 12-week GP without ribavirin interferon for 12 weeks in serotic patient. You can see achieve SVR up to 93%. So now it's very easy. You are serotic or not serotic. If not GP 8 weeks, if serotic GP 12 weeks. And that cure rate up to almost 100%. Therefore, I think new or update in HCV treatment, if you can access to soft well, you should use soft well, either serotic or non-serotic 12 weeks, except genotype 3, add ribavirin. But if you have GP in your country, now you use gicapivir, preventesvir. If no serotic, just 8 weeks. If serotic, 12 weeks, either the treatment or naive or treatment explained to PEG ribavirin, not DAA, only ribavirin, okay? This is a perfect regimen for new treatment in this 2018. However, come 2018, many patients, even we cure up to over 95%, but still minimum of them still truly not respond to DAA therapy. So DAA therapy become the big problem particularly I think in next 5 years we have to deal with minor population and become bigger when you cure for all white type population. This patient who fail from DAA mainly due to resistant associated substitution. So this can cause drug resistance, particularly if it higher than 104, and this can cause drug resistance. We got the good news because we got soft Velvox, again, sofosbuvir, velpatasvir, and voxeloprevir. 3 drugs, but in fixed dose combination, 1 tablet a day without ribavirin, without interferon. You can see either genotype, whatever kind of DAA treatment experience, they achieve almost 100% cure. And this also look at the SVR treated by soft Velvox for 12 weeks without ribavirin, and according to the resistant associated substitution, you can see no effect of RAS mutation among soft Velvox therapy. All of them achieve almost 100%, except that I mentioned the perfect net. If you look at 1B is 100% cure with soft Velvox, but it also 100% cure with soft Vel. Therefore, we recommend to go only soft Vel without ribavirin in genotype 1B. That's something that we still need personalized medicine in order to achieve the maximum cost effectiveness. Therefore, soft Velvox in many countries, including USA and Europe, still spare as a rescue regimen. We use soft Velvox appear in red color in for all DAA treatment experience. If in Thailand we can't do RAS, so we just use soft Velvox because RAS had no effect on the response to soft Velvox therapy. In the country where they can do RAS, you can see if the patient fail from protease inhibitor, you still use Gecapivir, Pibentazvir as well because it's cheaper. So we still spare some regimen. And as I mentioned earlier, you can see soft Vel can be effective among genotype 1B. Even they have NH5B treatment experience because SVR is still 100%. But if they want A, they require soft Velvox in order to achieve almost 100% cure. So this is still some a little bit issue, particularly when you're concerned about personalized medicine. But in Thailand, I think if you miss only that 1% and to treat all Thai patients, I think it cost effective in terms of try to eliminate hepatitis C in next 2030. So I mentioned that if the patient have SVR 12, that means undetectable HCV RNA, 12 weeks of treatment regimen, we call cure. However, look at this study. They look at the long-term outcome, follow up the patient for almost 2 to 5 years among those who actually achieve SVR 12, that considered to be cured from the disease. However, you can see among that 304,000 patients, it still have some patients who not achieve SVR. They become detectable again. And you can see actually 60% not because of relapse, but because reinfection. Patients, even they cure from hepatitis C, anti-HCV can be detected for all lifetime, but they don't develop protective antibody, so they acquire reinfection. Only few still have some relapse, but only few, it's just about less than 3%. Therefore, currently we recommend after 12 weeks, we do again 48 weeks after the end of therapy to confirm that they cure from the disease. And in some high-risk population, like men having sex with men, those who practice intravenous drug using, they might have reinfection. You need a good education, explain to the patient. And I think in USA now, they have a big problem of patients with intravenous drug using, they have reinfection because with 8-week treatment regimen, no side effect. And if they've been paid by the government, they don't mind to go back to some habit and develop infection again. So now this is a big problem in many countries, so we need a good education and work together. I think I learned from the HIV Society. You did a really fantastic job, how you prevent infection, how you try to work together in order to cure the disease. I think you are a good example. That's why I'm so delighted to join your meeting every year. So before I end up my talk, I will touch a bit. I think it's more complicated for you, but just let you see that there's still some issue because the world is still not perfectness. We still have some issue regarding the special group of population, including decompensated cirrhosis, patient with chronic kidney disease with GFR below 30 ml per minute, patient with HCV-HB co-infection, particularly in Southeast Asia, and also the patient who suffer from acute hepatitis C. Let's start with the decompensated cirrhotic patient. You can see they have some issue. Treatment is more limited among decompensated cirrhosis because protease inhibitor not allowed. It contraindicated. It can cause further hepatic decompensation and increase mobility and mortality. So you cannot have PI. Soft valve walk, Voxelicpivir is the PI, protease inhibitor. Gicapivir, pibentazvir, gicapivir is PI. So you can see some regimen now you can able to use among decompensated cirrhosis. And secondly, the lower response rate seen particularly in those child B and C, and we might still require ribavirin in order to maintain high SVR. As I mentioned, we don't like ribavirin because it still contains side effect, but in this popular group of patients, we might have to use ribavirin. And we might have to extend the treatment duration to 24 weeks, particularly among those who cannot tolerate to ribavirin. So this gives you example of two famous protease inhibitor. You can see this exposure level among decompensated cirrhosis comparing with those who have normal liver function. You can see, but level it increased up to 5 to 11-fold higher in decompensated cirrhosis in Voxelicpivir and pibentazvir respectively. So you can see this, there's ledipasvir, support-vivir, ribavirin. For 12 weeks and 24 weeks, you can see you can achieve almost 90% SVR. But the bad news, you can see the bottom line is the serious adverse event. You can see serious adverse event can be seen up to 1/3 to almost half of the patients. So to deal with it, I think you better to allow hepatologists to take care because you have to do a lot of side effects. And you can see ribavirin had to be low dose because it contains a lot of side effects among decompensated. Usually, we initially start with 600 milligrams daily. And another one, soft well with or without ribavirin, you can see that soft well with ribavirin 12 weeks, it gives you 96% SVR in decompensated cirrhosis. So this regimen for decompensated cirrhosis, which I think please give to me. I had no job to do for decompensated cirrhosis because there's something to be considered among this decompensated cirrhosis. You can see if you want to treat them, yes, of course, they can cure from the disease. They might be able got a fantastic result, be deleted from liver transplantation because they come to be compensated cirrhosis and no longer require liver transplantation. You can improve their quality of life and survival. However, what is the risk? If you treat them, we not use positive HCV positive donor, so they have to be on the waiting time longer because we use HCV positive donor only among HCV positive patients. Secondly, you might delay liver transplantation because they improve slightly better. You move them up a bit from waiting list, but not able to delete it, so they suffer on that situation. Okay, that's why we call male purgatory. You put them in another purgatory because they not can be transplanted and they're cured from disease, but they still suffer from cirrhosis and have a risk of complication of portal hypertension and liver cirrhosis, including hepatocellular carcinoma, and that we call pale purgatory. So this shows the benefit. Of course, even in decompensated cirrhosis hepatitis C, with DA treatment, you can improve transplant-free survival. You can reduce the risk of hepatocellular carcinoma development, reduce the risk, but not eliminate it. Therefore, this still requires surveillance for hepatocellular carcinoma. Look on the male score. You can see if you treat the patient decompensated but male below 16, you can see that the risk of dying from waiting list low, but the risk of transplant also low, but they can survive and become compensated quite high, up to almost 70%. But higher male score, they have the higher risk of dying while being waiting for liver transplantation and require liver transplantation. So this just sum to the conclusion, this how to manage the decompensated cirrhosis. We classify the patient according to male score. If they're male below 16, go ahead, treat the patient with DAA because 70% of them will be survive and be deleted and live with the compensated liver disease. Male between 16 to 20, they borderline, they might improve but not truly compensated and still require liver transplantation. Therefore, we have some parameter. If the male score improve at least 3 points, if they have improved in serum albumin at least 0.5 gram per deciliter, we can delist them because they survive quite well. But if they still have no this parameter improvement, they still have some complications. So keep them in waiting list but not in an active position. Okay. If the male above 21, I think better to treat them after liver transplantation because you might put them in male purgatory. They cure from hepatitis C but still decompensated, quality of life not good, still have a risk of complication of portal hypertension such as varicose hemorrhage and still have the risk of hepatocellular carcinoma. So in that country, we better to treat after liver transplant, except like in Thailand and India where waiting list is so long, we still shortage of donor. We might consider treatment who have male above 20, but it has to be under specialist and in the special center and discuss risk and benefit with the patient. I will end up with the male purgatory. It means the lack of improvement from decompensated to compensated cirrhosis or child A, but male score below 15. Why? Because male score below 15, they will be deleted from liver transplantation waiting list. They cannot be transplanted, but they still suffer from liver cirrhosis. That we call male purgatory. And this, they have some new study called BE3A score to consider who able to be deleted and not suffer to stuck in the male purgatory. That this score actually we use for clinical very easily, BMI, encephalopathy, present or absent of anxiety, serum ALT level and serum albumin. And if the patient have BE3A score above below 3, don't treat them because they will fail in male purgatory. But if they have high P3A score, treat them because they will respond well and become compensated cirrhosis. For kidney disease, I will have only one slide that gastrosuperior elbasvir do not need dose modification and safe in chronic kidney failure patient even with or without hemodialysis. You can see HVR approaching 100%. And another one is GP, also pan-genotypic and not excreted to the kidneys, so they don't need require dose adjustment and can be treated even in those who end-stage kidney disease. I come to the most important one in our region, hepatitis C and hepatitis B co-infection. As you know that when you treat hepatitis C, the patient achieve SVR, cure from HCV, but you might reactivate hepatitis B, then patients suffer from hepatitis B flare again. You can see 30% of HCV, SBV co-infection have hepatitis B flare after cure from hepatitis C. But for those who only anticore positive or occult, you can see the risk of flare is minimum if it does. So we only consider those who have S antigen positive. Come to the conclusion. If the patient hepatitis C, particularly in Asia Pacific region, you check SBS antigen. If they're negative, either anticore positive, negative, you do not think to treat hepatitis C. If they're anticore positive and they have unexplained ALT elevation, okay, so that you have to look for hepatitis B reactivation. But for those who have antigen positive, look at the DNA. If they fulfill the criteria for Hep B treatment, give them DNA plus nucleoside or nucleotide. Particularly in your patient, we have tenofovir and emtricitabine already. That's perfect. So if they not met the criteria for hepatitis B treatment, just monitor them during the treatment until 3 months after the end of DA therapy. If they become more than 1,000 in those who baseline DNA undetectable or rising in DNA more than 10-fold, then we add anti-SBV therapy prior developing hepatitis flare. So come to the last group, 2 more slides. It's about acute hepatitis C. Acute hepatitis C, it means the patient who infection but still less than 6 months. Something to consider. 1/3 of them can be cure spontaneously, not require treatment. So if you treat everyone, you might treat another 30% who not require HCV therapy at all. Secondly, it responds to interferon, even interferon high dose without labeling for 16 to 24 weeks, SVR 96%, but people don't like interferon. And then most patients who have hepatitis C acute infection, they are symptomatic. You cannot diagnose them. Mainly you see the patient who hospitalized and have pneumothoracic injury, or you have some procedure. It's some quite bad news. In India, they reported the annual nosocomial acquired hepatitis C infection is up to 2 to 6% per year. And mainly if you go to the dental care, it's where they have a transmission of hepatitis C treatment with the healthcare provider. Lastly, DAA is very effective in chronic. Why we need to treat acute? We can wait them until chronic. They not go to cirrhosis yet. So this one study is a software, only 6-week treatment regimen without libavirin in those who acute HCV infection. You can see software and lenipasvir, for only 6 weeks, you see SVR 100%. Therefore, I would say that among those who diagnose acute hepatitis C infection, try to discuss with the patient. And myself, and even many national policy, including Thailand, we prefer to do the delayed treatment. Because don't worry, after 6 months, you chronic hepatitis C, but no cirrhosis yet. Treat with DA, you also almost 100% cure. Okay? If the patient accept that idea, you just follow up for 6 months. You can see 30% can cure spontaneously, and that you save money for 30% of that patient. If they confirm positive after 6 months, then you treat them with DAA, with now only 8 to 12 week treatment regimen up to almost 100% SVR. If they're not acceptable, they said, no, I don't want any stigmata in my body, treat me now. I would say that in Thailand or in many countries, who reimbursable should be paid for their own pocket. Because they buy convenience, they buy their happiness, but they might suffer to the budget of the country. So I would say that, yes, you can get treatment, but pay by yourself. And it's not expensive in Thailand. As I mentioned, it's $200 for treatment. Monitor them 12 to 16 weeks, but still 12 to 16 weeks, because most who cure spontaneously will be cured within first 16 weeks up to over 95%. So you meet only 5% of that 30%. Okay, minimal. Then you start treat them with DA. The thing is only 6 weeks. 6 weeks it cost the patient only $250. So let them pay by themselves. Mr. Chairman, ladies and gentlemen, I would like to conclude my talk today regarding update in hepatitis C diagnosis and treatment. C core antigen is reasonable tool for diagnosis and treatment monitoring for patients of hepatitis C infection, as it's much less expensive, about half price, and also more convenient, not require expertise of performer, and is automated. Pan-genotypic, highly effective DNA such as software are now available in many countries, so it will be treatment of choice, particularly in Thailand. Interferon-free, libavirin-free, gicapivir, and preventosvir is really pan-genotypic. In the country that you have did said, I choose this one. Only 8-week treatment duration for non-cirrhotic and 12-week treatment duration for cirrhotic patients. Please spare software work for rescue therapy among those who have DA treatment experience or been confirmed resistant associated substitutions. There are still some issue with I just cover in one conclusion, because please let to be my job among those who are specialized group of patients, decompensated cirrhosis, those who have SCC or acute infection. And then I thank for your attention.
Great, thank you very much, Ajahn Teerha.